Hello everyone, welcome to Surgery Dada. So today we are back with the Bedside clinics with my surgery residents. So we have, let me introduce you to my team. We have Dr. Shriram Iyer, he's a resident, and we have a senior resident, Dr. Jay Prakash. So this is a case of acute appendicitis and we shall have a complete bedside evaluation of the patient. So what is the summary? Just give me the brief summary of this patient.
This is a 26-year-old male patient presented with chief complaints of pain in periumbilical region since one day, and he has no history of vomiting, he has no history of nausea, and there is no history of any constipation, there is no history of any burning micturition. Except these symptoms, there is no other history, sir. And in the past history, if you go 10 years back, he had a history of tuberculosis for which we underwent 6 months course of ATT.
Okay, so this patient came to ER with a classical complaint of pain over the periumbilical region with a fever also since last 24 hours. And on ultrasound, it was seen that there is a blind aperistaltic loop with significantly thickened, you can say, structure, and that is probably suggestive of acute appendicitis because the exact diagnosis can be done only after histological assessment. However, the diameter, the internal diameter of this appendix, inflamed appendix, is 12 to 13 mm. So, whenever we have the patient of acute appendicitis, what is the name of the score that we have? Can you give him the mic? Okay. So, what is the name of the score that we have and what are the classical parameters that we have?
Okay, the name of the score is called as Alvarado score.
Okay.
And we can remember it with the mnemonic mantral. So, what is mantral? Mantral is migratory pain. Then A for this anorexia, N for nausea, T for tenderness, and R for rebound tenderness, E for elevation of temperature, and L for leukocytosis and shift of neutrophils to the left.
Yeah, this is very important score because dear students, many a times the appendix will not give us time for the radiological assessment and it can rupture. So yes, according to the Alvarado score, if the score is found to be more than equal to 7, yes, it is clinically suggestive of acute appendicitis and we have to go for appendicectomy. Now, when we are going for the assessment of this patient, the very important sign that we have to understand is the McBurney's tenderness. But before going to that, let me tell you that this patient had a classical complaint of periumbilical pain. So when we talk about this periumbilical pain, why is this periumbilical pain? Because the visceral peritoneum to the appendix or the blood supply, the nerve supply is T10 and T11, and that is why this is the area where the pain is referred. Now, as the inflammation exceeds its domain, it involves the parietal peritoneum also, and this is the appendix which is inflamed and it touches with the abdominal parietus and thus it gets fixed here, adhered here, and that is why we have a classical McBurney's tenderness. To evaluate the McBurney's tenderness, we need to understand where is McBurney's point. So this is umbilicus, this is your ASIS, and this line, this is known as a spino-umbilical line. Medial 2/3, lateral 1/3, this point is a classical McBurney's point. So when we want to assess this McBurney's point, with the pulp of the finger, you will take it, you will press it, and just when we press it, just record the expression of the patient. Just see. Can you see? I'll show it here and quickly. Yeah. Can you see the tenderness? And this is classical McBurney's tenderness. If you insinuate your fingers, even normal patient will have the pain without appendicitis. So it's very important to correctly demonstrate this sign. Now, I would ask you guys, tell me what are the other signs that you have, and you will have to demonstrate that.
Okay, we have something called as a rousing sign.
Yeah. So what is rousing sign?
Rousing sign is that we will have to put pressure on the left iliac fossa, sir, and if and the positive, if the sign is positive, the patient will have a tenderness on the right iliac fossa.
I'll let me demonstrate it to you and explain the reason. So just see, when we go for deep palpation over the left iliac region, what is happening? The viscera is lateralized towards the right iliac fossa, and that is why there is pain. So Dr. JP, can you demonstrate and tell me about the classical Cope-Swas or the obturator sign, and to me, what is an obturator sign and what is a Cope-Swas sign?
The obturator sign.
Give him the mic. Yeah.
We flex the thigh and external rotate at the level of knee joint. So the internal rotation happens at the hip joint, and then we can see if there is any pain on him.
So usually what happens when we do the internal rotation at the level of hip joint, the appendix comes in contact with the obturator, and thus the referred pain is at the level of hypogastrium. There is one more sign which is known as Cope-Swartz sign. These are the signs which are typically used for what category appendix?
So Cope-Swartz sign is used to identify the retrocecal appendix.
Yeah.
And operator sign is used to
For
see the
pelvic appendix. Very good, very good. So how do you demonstrate this Cope-Swartz? Can you demonstrate it for us?
Cope-Swartz. ये पैर उठाओ आप
दोनों उठाना without flexing the. So you'll ask the patient to elevate both the legs without flexing. So yes, there is no pain. So that means the Cope-Swartz is negative for this patient. Now, when we talk about appendix, we have to understand there is a huge anatomical variations in the location of the appendix. So the most common site for appendix is the retrocecal variety. The second one that we have is the pelvic variety. Then we have paracecal, subcecal, pre-ileal and post-ileal. Now, we have done the diagnosis. Everything is okay. Now, we are planning for a surgery. So, before surgery, when you're doing a clinical assessment, what is the most important clinical assessment that you will do before deciding to go for the appendicectomy?
Mentals.
No, that is okay. When we talk about the clinical profile, we need to do a superficial grazing of this area to feel whether there is a lump or no. And why? Because if there is a lump, that means there is dense adhesion and formation of a phlegmon. And in that case, you might or you should avoid the surgery at that point of time. Go for a conservative management and reassessment after 48 hours. And this is what is known as Ochsner-Sherin regimen. Now, what are we going to plan in this patient? We are going to plan a lap appendicectomy. So when we are going for a lap appendicectomy, the most important thing is the port positioning. So if we go for open, so we have lot of incisions. So this is McBurney's. This is an incision which is perpendicular to that. So this is a classical gridiron incision or a MacArthur's incision. You can also go for incision along the Langer's line. And what is this known as? This is known as a Lanz incision. We can also go for a horizontal and transverse incision. What is this known as? This is known as Rocky Davis incision. Many of a time when we are going for these incisions, if we require more space on the lateral side, this is known as Rutherford-Morrison extension, and this is a muscle cutting. When we want to go for a medial extension, this is known as a Fowler's-Weir's extension. Remember, the Lanz, the McBurney's or MacArthur's or the classical Rocky Davis, they are all muscle splitting incisions. But when we go for the Rutherford-Morrison, it's a lateral extension. Yes, you have to cut the muscle. So Rutherford-Morrison and Fowler-Weir are muscle cutting. Now in this case, we are going to go for a lap appendicectomy. So let me demonstrate the port positions. Now let us talk about the port positioning. So when we talk about the port positioning, the very first thing that we have to identify is the target. So this is the McBurney's point and this is the target. So here we have a lot of spirit. The most important thing is identification of the target. So this is your target. Understand, this is the target that we have. Now we follow a baseball concept of port positioning, or this is known as triangulation of the ports. So both the index should come at the level of target. This is very important. Both the index should come at the level of target, and both the thumbs where they are touching, this marks the ideal position for the camera port. So just see, in this case, this has to be somewhere here. It has to be the camera port positioning. So we'll go for this. Now you have to understand both the anatomical snuff box. So one port, so this is the anatomical snuff box. So one port has to come here and the another port has to come here, somewhat here. Dear students, if you see, this is how the appendicectomy is done. This is working port number 1, this is working port number 2, and if you see, the angle between them is a manipulation angle. Now this is a contralateral port positioning, so you get a better manipulation angle. If you use ipsilateral port positioning, so one port will come here, one port will come here. If you see in this case, the manipulation angle is very less, and that is the time when you actually struggle. So this is an ideal adult abdomen, so you are not going to have that many problems. But in case of pediatric abdomen, if you make a habit of making a camera port at umbilicus, suppose this is a pediatric abdomen, this is the appendix, here is the camera port, so you will never be able to visualize the structures. So always remember, we need to follow the proper triangulation of the ports, and remember this. So both the index point towards the target, both the thumbs, they point towards the camera port, and both the anatomical snub boxes are going to point towards the working ports. Remember, the angle between the two working ports at least should be 30 or more than that. And to achieve this, the two working ports should be at least 5 to 7.5 centimeters apart. So thank you for watching this. Let us go and enter into the OT and check out the second video for the operative steps of lap appendicectomy.